Hello, thanks for watching us. I'm Debrief from Paris, France. I'm hepatologist, and I'm very pleased to share this moment with my friend and colleague, Professor Agustin Albilos, hepatologist in Madrid, Spain. So today we will discuss about the issues about cirrhosis and liver transplantation. Well, let's start with the concept of cirrhosis. So, Agustin, why do we talk about cirrhosis?
And we talk about cirrhosis because it represents an important disease with an important burden of disease in the world and in Europe. And as it has been remarked by the state-of-the-art lecture in this meeting by Professor Bosch, 2.8 million people in the world suffer from cirrhosis, and it represents and it results in a significant mortality. Moreover, and specifically in Europe, cirrhosis causes 170,000 deaths, which is a number higher than breast cancer. And now than direct antivirals are reducing and eliminating hepatitis C, alcohol is the leading cause of cirrhosis in Western countries. Regarding etiology and alcohol, is there something that we can do to help our patients to withdraw from alcohol?
Alcohol is a tricky issue, right? And here, well, we saw a very interesting study, which was in fact a French study, maybe because in France, alcohol is an important problem, is an important issue, and an important cause of chronic liver disease. And we saw this French observatory multi-center about the use of baclofen in alcohol-dependent patients. So this is very interesting, as usually we are not very happy to use those kind of medications in cirrhotic patients because we fear they won't be well tolerated. So the authors included 200 patients, and in fact 100 were followed up until 1 year. And what they saw is that 2/3 of them either decreased or stopped completely their alcohol consumption under baclofen, which is a very good result. Noteworthy, it was very well tolerated in cirrhotic patients, and they could really have a dosage which was correct of baclofen and which was efficacious. And the last thing, which is very important when considering the 77 cirrhotic patients of this study, is that their liver function improved. As we saw with antiviral agents, it was the same with stopping alcohol. So this is good news. These are good news because baclofen and other medications like that could be promising medications to treat alcohol dependence and hence to improve the prognostic of cirrhosis by restoring liver function.
You are right that hepatologists are reluctant to use baclofen and this medication in the clinic. Do you think that according to these interesting results of the French study, we should begin to use drugs to improve and enhance abstinence of our patients? You have just told us that this drug baclofen seems to be very safe with very few adverse events in this population.
Absolutely.
What is your impression?
Yes, absolutely, Agustin. In fact, starting when this study started in France, we were aware of this and we started to use it also, and it really works and it's well tolerated. So my answer is yes. My other answer is that we have to work hand by hand with alcohologists to also treat psychologist effects and to treat dependence. And this is very important. But yes, this is really something promising, and we can treat our cirrhotic patients without any problem. Yeah.
Okay.
So if we can treat the cause, that's very good. However, it's not always the case. And for example, NASH, we don't have very, very good drugs right now that are approved for NASH. We all know this. This is a future direction for hepatology. So when we cannot treat the cause, what can we do to prevent the complications, being the complications of portal hypertension, for example, or liver failure?
Well, one of the most commonly used and important drugs that the hepatologists should use and should wisely use are beta blockers. Beta blockers are an old medication that we are learning every day the benefits, the important benefits in our cirrhotic population, but also some of the harmful effects. In this meeting, there have been 2 studies focusing on the heart as the nucleus, as the area where beta blockers can be harmful for the patients, and because they further contribute to impair the circulatory dysfunction of this patient. The 2 studies addressed, one is from the group of Dr. Villanueva in Barcelona. They show that in patients on beta blockers with a cardiac output lower than 5 have lower survival than those with cardiac output greater than 5. Whether our study shows that the reduction in systolic function by beta blockers is greater in patients with greater vasodilation and correlates with the impairment in renal function. What does this mean? That we should withdraw beta blockers in a patients with a cardiac output lower than a certain cutoff? Not at all. The bottom line, the practical bottom line of these studies, clinical and pathophysiological studies, is that we should use beta blockers as any other drug properly. And the proper use of beta blockers includes to be very cautious with using them in patients that get benefits from them, but who have a compromised circulatory function, which are patients with ascites. So in all patients we give beta blockers, but especially in patients with ascites, we should adjust doses to the circulatory function. We shouldn't adjust those to have a heart rate above 50 or 55, and to adjust doses to have a systolic blood pressure above 90 or 100.
Yeah, this is very important, and if I understood well, there are very severe patients with ascites, for example, but the most we have circulatory dysfunction, the most beta blockers will work. So that's where we should use them, but the most they can be harmful. So I have a question for you, which is about carvedilol, especially in primary prophylaxis in patients with ascites. What would you advise to hepatologists?
Carvedilol is a very useful drug. Carvedilol has shown hemodynamic effects in patients with cirrhosis only in the setting of primary prophylaxis. Carvedilol is more powerful, combines the effects of a beta blocker and of an alpha-1 blocker, so it vasodilates the liver, but also the systemic circulation. So increases the vasodilation of the cirrhotic patient. In summary, carvedilol is useful. Carvedilol can be used in the setting of primary prophylaxis, or it has not been adequately proved in the setting of secondary prophylaxis of bleeding. And third, since it can potentiate vasodilation and increase the circulatory dysfunction, it shouldn't be used in patients with decompensated cirrhosis, specifically in patients with ascites or with previous ascites. So the proper setting group of patients to use it is compensated cirrhotic patients for primary prophylaxis in compensated patients with cirrhosis.
Well, thank you, Augustin. This was very clear for carvedilol. So now everything is clear. So moving on, once we go ahead beta blockers, I think also that one tricky issue is the issue of infections.
And really, something new in this meeting about bacterial infection.
Yes. So there was something new. Really, we know that infections are a concern, and especially multi-drug resistant infections. And here there was one big multi-center international study, which is called the Global Study, which was led by International Ascites Club, and which studied epidemiology, predictors and outcomes of multi-drug resistant bacterial infections in patients with cirrhosis across the world. So this is a very important study because it's around the world and because 1,300 patients were included. So that's a lot of patients, and this is the first so big study on the topic. So what was seen first was general considerations. UTI infections, pneumonia infections, and SBP were the most common infections, and this we knew this already. However, what was noticed is that more than 1/3 of patients displayed multi-drug resistant or even XDR infections, which means very, very resistant pathogens infecting the patients. And this is rather new, and the investigators looked at the distribution across the world of those infections. And what they saw is that there were some regions with very high prevalence of MDR, which were North America, Canada, South America, Asia, and especially India. India, they had a lot of MDR and XDR. And what was seen also, and this is very important, that this was influencing prognosis.
I'd like to ask you about what happened and what is the practical implication for instance, we in Europe we see many people that are immigrants from these countries and has that high prevalence of MDR in South America, India, and has practically has implications for our practice?
Absolutely. Thank you very much for the question, because this is a tricky issue. We have a lot of patients coming from other countries, and especially patients coming from Asia and from India especially. I would advise really to isolate them when they are admitted in ward or ICU and to give broad spectrum antibiotics, because it was shown also that patients coming from India, if you tested the susceptibility to antibiotics of the germ, it was always below 80%, even for carbapenems. And very importantly, this was conditioning the prognosis, meaning that patients with MDR were dying more, and that the resistance of antibiotics was independently associated with mortality as well as liver function, of course. But this is a really important issue. So two things. It's important, and we don't have the solution right now because we have some patients that display germs not sensitive to any antibiotic that we have at disposal. And the second thing is to be very cautious about patients coming from other countries and admitted in your unit. The third thing is also that in your unit, you must know the ecology of your unit, which is specific to your unit, and work hand by hand with microbiologists.
Did they address the risk factors for having MDRs in this study?
Yeah, they addressed the risk factors for having MDR, and the risk factor for MDR was coming from Asia and especially India or South Africa, the antibiotic use within the 3 last months, the fact of having been hospitalized before, and nosocomial infections, and also pneumonia, UTI, and cellulitis, which is quite common and was already well known. Mm-hmm. But being in the healthcare system is not good, because you can develop more nosocomial infection. It's not good for infections, it's good for the rest, of course. But this is really an issue. This is an issue we will have to face the years coming.
But we should be very cautious about this problem and the important impact and in resolution of infection, of course, and in that cause the adequate choice of the empirical treatment to therapy. Do you think that this is an important issue, and how we should be adherent to current guideline recommendations, and how this can impact the outcome of our patients?
Yes, indeed. As you know, EASL provided recommendations in 2014 extending the spectrum of antibiotics in a nosocomial setting, for example, extending it to tazocilin, piperabactam, and also to carbapenem in certain specific settings like nosocomial infections. However, when you look inside this global study, for example, only 60% of physicians were following the recommendations for their patients. Some of them gave weaker antibiotics, and some of them gave larger spectrum antibiotics. So only 60% of people had the right antibiotherapy following the recommendations, which is not good because following the recommendations was associated with a better prognosis and a better survival. So this is very important, in my opinion, to follow the recommendations. So Agustin, what would you advise us to decrease the prevalence of MDR and XDR bacteria?
The wise use of antibiotics. You should only use antibiotics when they are really needed. And now you have enough tools in your armamentarium to diagnose and to be sure, or to be acceptably sure that an infection is present. Most of the studies nowadays observe that prophylaxis, antibiotic prophylaxis, quinolone prophylaxis is a risk factor for having or for developing infection by MDR bacteria. So an essential aspect is to tie the use of antibiotic prophylaxis to the established indications. And we should know then, and we should also know the results and the efficacy of primary and secondary prophylaxis of bacterial infection of SBP. Something new in this regard in the meeting?
Yes, in the meeting, Jean-Michel Bajaj reported the results of a study of the NASL American Consortium, about 300 patients under primary or secondary prophylaxis of SBP. And he looked at the different outcomes between the two settings, but the most important thing which was noticed in this study is that still 10 to 20% of patients under primary or secondary prophylaxis of SBP will develop SBP. So it means that we have to question this prophylaxis of SBP in the years coming. Well, it seems that we won't have enough antibiotics to cover all the germs because some bacteria are becoming more resistant and we won't have any antibiotics covering them. So what could we do to go beyond?
This is a fantastic question, Dominic, because something that is becoming better known in nowadays is the influence of the gut in the liver, the so-called gut-liver axis, and how the changes in the gut microbiota and in the gut microbiome, those metabolites and products that all those bacteria produce influence the natural history of cirrhosis and the developing of complications. And in this meeting, there have been the results of two studies that they further demonstrate, but because it was already partially known that there is a reduction in microbial diversity in the gut in patients with cirrhosis. The greater the severity of the disease, the greater the severity of cirrhosis, the lower the diversity of bacteria in the gut. The lowest diversity is observed in patients with acute and chronic liver failure, as it is shown in one of the studies that have been presented in this meeting. It is important that in addition to this microbial diversity, as the greater the severity, the greater the number of proteobacteria that are those that cause many of the infections that we were talking about just a minute ago. But this microbial diversity, as it has been shown in this meeting, is observed in Western this decrease in microbial diversity as the cirrhosis progresses is observed, or has been demonstrated or shown in this meeting in two populations, Western populations, a Spanish one, although a Mediterranean country, and I will tell you now why I say that, and in the US. But if you analyze a cohort of patients, cirrhotic patients from Turkey, you see that these patients, the microbial diversity, the reduction in microbial diversity as the disease progresses disappears. And always patients from Turkey have a greater microbial diversity in the gut than the Spanish or the American counterparts.
Interesting.
And because of this, these cirrhotic patients develop less complication. The number of hospitalizations of the patients from Turkey is lower. But the factor that seem to influence this greater microbial diversity in patients, or the preservation of microbial diversity in cirrhotic patients from Turkey is diet. And the components of the diet that influence microbial diversity are coffee and tea, vegetables, fermented milk products, and chocolate. The practical point is that diet influences the progression and the natural history of cirrhosis. And we should recommend a healthy diet to a non-cirrhotic but also to a cirrhotic patient. And from my point of view, that is something that is often forgotten in our outpatients clinics.
Indeed, this is very important. So when we move on, if this doesn't work and we have to go further, I think that we will have to go to liver transplant, right? What do you think about this?
Well, liver transplant is a perfect option, an excellent option for patients at the very end, at the very far end of cirrhosis. And options for liver transplantation or indications for liver transplantation are changing now in Europe. And in this meeting, we are seeing the use of direct antivirals is extensive in Europe and in the United States. The number of the indications of liver transplantation for hepatitis C patients are declining, are dropping, both in the United States, as has been shown in the data from the UNOS registry, and also in the Italian registry that has been shown in the meeting. And at the same time, again, the first indication for liver transplantation now in US and in Europe, in Italy, is alcohol. But the number of patients with NASH cirrhosis is increasing, especially in the United States, but also in Europe. But an important point that should be addressed here is that whereas in the United States it represents nearly 20% of liver transplantation indication, in Europe it is less than 10%. But it's something that is increasing, and we should be aware of this, and what are the outcomes of liver transplantation in this specific population. Do you know something about this?
Yes, Augustine, there was a very nice study which was presented for the ELITA group, which means the European Registry of Liver Transplant, and they focused on the liver transplants for NASH. And one fear would be that those patients would not survive as well as the others because they have comorbidities like cardiac, arterial comorbidities. In fact, what they observed, first thing, as you already said, the incidence of liver transplants for NASH is way increasing in Europe. And this is really clear, and this is not the case of other causes of transplantation. The second thing, when you look at the patients transplanted for NASH, they have a higher BMI, of course, and they have more HCC. The third thing, is that they have the same prognosis than the others. In fact, the thing which is influencing prognosis is having an HCC or not. But the cause of liver transplant, especially for NASH, is not influent for the survival. And survival is the same in NASH and non-NASH patients after transplant. People die usually, as usual, from infections and cardiovascular diseases. And so the message here is this is a growing population and a growing indication of liver transplant, but the prognosis is good. It's the same than in other causes of liver transplantation.
Okay.
We are here talking, of course, of patients with cirrhosis.
We are talking about cirrhosis, but another cause of liver transplantation is acute liver failure.
Well, yes, there was in fact a French study, which was a French study on a special type of acute liver failure, which is acute liver failure of unknown causes. This happens pretty often, in fact, that we don't find the cause, and so this kind of ALF has a bad prognosis usually. And so this was an observational study, prospective, of 70 patients with acute liver failure of unknown cause, and the prognostic was studied, and also retrospectively if the investigators could find some causes. So the first thing is that 43% of the patients got transplanted, but they got transplanted, but half of them without the usual criteria for ALF. The second message is that patients who were transplanted survived more than patients not transplanted. And this is very important because 20% of patients not transplanted died, and only 12% of patients which were transplanted, which means that probably choosing criteria transplant is a good thing for those patients. And the last thing is that looking back, we could find in more than 50% of cases a cause of ALF, but after the story, and the main cause was, as expected, autoimmune hepatitis.
How those findings of the French study translate in the decision making in patients with acute liver failure regarding the decision to indicate a transplant?
Well, my message would be that this is doable with a better prognosis than not transplanting, that probably we will have to revise the criteria, and probably we will have to establish a database and to look at those patients very carefully. And I know that the Paul Bruce team is working on new criteria for this kind of acute liver failure.
Okay.
When looking at this, I don't think that at the end of our career, my career, your career, we will still transplant so many patients. What do you think? Because transplant is a good thing, but it's the death of the liver also. So are there any new option, exciting option, promising option
for
treating
patients? Well, there is an active search for all these alternatives to liver transplantation, and one that has been studying for some years, and of which we have some examples in these good examples in this meeting, is stem cells transplantation, and an experimental study from the liver unit from Barcelona, from Jordi Gracia. They showed that transplantation of stem cells, mesenchymal stem cells, to rats, cirrhotic rats with carbon tetrachloride cirrhotic rats, is able to reduce portal hypertension. And well, stem cells probably work in a paracrine way, producing substances that have an immunomodulatory effect. So these investigators show that injecting these cells, peripherally injecting these cells, they are able to reduce inflammation in the liver, reduce intrahepatic vascular resistance and so portal pressure, and halt the activation of hepatic stellate cells and the production of which are the driver of fibrosis production. So these results are very promising.
And yes, and have you seen this very interesting study 1 year ago published in Cell by Falk Institute in US, which were the investigators were injecting cells from humans to a pig. It was pancreatic cells. And after some months, a human pancreas was developing inside the pig, which was chimeric transplantation, syngenic.
I know, yeah.
And so this was completely crazy. And have you seen that there was also one abstract here? So we are not dealing with human, unfortunately, but with rat and mice, which are kind of a little far from humans, right? But still, this is a proof of concept, and this is the first one, and you notice this study. And so they took some mice and they took some rat, and they injected cells, hepatocytes, from mice to the rat. And after, they followed. So it was a syngeneic transplantation, with a chimeric transplantation with autologous hepatocytes. And they looked at the survival and the weight of the liver of the rat. And what they saw, and this was fascinating, it was after few weeks, and with immunosuppression, of course, the liver of the mouse was developing inside the rat. And in fact, this liver was 10 times heavier than in the beginning after 3 months, showing in this proof of concept that we can do this. We can inject autologous hepatocytes inside another animal and have the liver grow.
And how did they deal with the issues of immunological reaction and all this stuff in these mice?
Well, this was very interesting. Well, of course, all the animals were treated with tacrolimus as an immunosuppression, but this works in certain animals and not in others. And for example, we know that mouse, rat, it works. But with pig, probably it doesn't work so much. And so we have to study this, of course.
Well, anyhow, it's a fascinating area of research and a hope for all patients with advanced or acute, chronic or acute liver injury, because otherwise, well, as the problem and as the huge amount of disease that represent cirrhosis, well, we are not having, and we have a big gap between the need of liver transplantation and the real number of donors that we have. And I think, Dominic, that in this meeting we have had a complete overview and advantages in any of the aspects that cover that cirrhosis covers, from aspect to enhance alcoholics to withdraw from alcohol, to going through the proper use of beta blockers and of antibiotics, the relevant aspects of bacterial infections and MDR infections in our patients, and the growing issue of NASH as a cause of cirrhosis, and the good outcomes of liver transplantation in this population. So it has been a pleasure to share this time with you and with all the audience. And
well, it was a pleasure too, Augustine, and well, it was really an exciting meeting indeed. So thanks very much, Augustine, and thanks very much for watching, and see you next year.